Good evening, everyone, and welcome. This is the additional webinar organized by the University College of Osteopathy in collaboration with Mayo and CAM Collaboration. Today, we have Professor Jorge Esteves, who will be talking about enactive osteopathy, a predictive processing framework to managing patients with persistent physical symptoms. Jorge, besides being a very close friend of mine, is a great professional, great researcher, and with a big brain and a very critical mindset. This last aspect will help us to understand what is predictive processing in the framework, a new model of understanding osteopathic practice, in particular applied to pain and persistent pain and persistent physical symptoms. This is going to be a 1 hour 30 minutes webinar where we have after the presentation of Jorge, we have a panel composed by also Hilary Abbey, also from UCL, which will also moderate the discussion afterwards, who will moderate the discussion afterwards. So it's a very great pleasure for me to leave the floor to Jorge, and please keep following him, and you can also post your questions on the chat, and then we'll have back to the discussion in order to pose to Jorge and answer them. The last notice is the ends out. So if you click on the ends out tab on the right upper right corner, then you can also directly download the presentation. So again, Jorge, thank you very much for this, I'm sure, interesting topic, and see you in a bit.
Thank you very much, Francesco. Interesting topic, and of course you were part of the developing model anyway. Okay, so hello everyone from Saudi Arabia. So some of you, I've noticed that some of you are attending again, another webinar on a kind of similar topic. So this is an evolving model. We are working together. So Francesco, myself, Hilary, and other colleagues in developing this model, and currently working on a paper or a couple of papers that hopefully will be submitted very soon. So it's there are some changes from previous presentations. One done in April, and another one for friends from Portugal and Brazil, done in Portuguese at the beginning of last month. So as I said, it's evolving. So new ideas. So this is the outline for today. So we're going to start talking a little bit about pain, persistent pain, and other physical symptoms, and try to link that to concepts of body agency and osteopathic models. And within the osteopathic models, just do a very brief critical appraisal of those models, and then move on to this idea of inactivism and osteopathy. So try to understand a little bit about what is that, and from that sort of jumping into predictive processing, as a kind of introduction and a link to clinical practice. And then we'll finish by trying to understand actually what can we do with all these ideas. The bottom line is, how useful is this in clinical practice? How can I use this to inform my practice and ensure that I do my best possible work as an osteopath? And we'll finish with some a little bit of discussion about the ideas that we're proposing. So remember, a lot of this stuff is still very speculative, needs to be properly peer reviewed by experts in the field. So we can develop something that would make sense, not just another idea, but actually something that is robust enough. So we start with a little bit of context. Always important to put this in in context. This is a real patient of mine here in Riyadh, so a 37-year-old female patient with the typical kind of presentation for osteopathic practice, not just one thing, but actually there's a kind of a range of symptoms, arguably all associated. So persistent neck pain, left-sided upper back, chest pain, headaches, abdominal pain, IBS symptoms, etc., and with a history of anxiety-related breathing problems, miscarriages, and the recent benign ovarian tumor. And she's been, she has done the rounds in terms of healthcare professionals, has visited a cardiologist, a gynecologist, neurologist, several physios, minimal improvement in her symptoms. And she has been told that, she's got a little bit of wear and tear in her cervical spine, and that is the cause for the pain. And importantly, there's nothing wrong with her heart or breast, because as you can see, there's a sort of left-sided chest pain, and, quite a lot of worry about actually what's going on. Now, the interesting thing, there's a couple of things here. One is she's constantly aware of her neck and chest, so it's kind of something that is very visible as a body part, and despite reassurance from doctors, everything is fine. She's still extremely worried about, she may have breast cancer or a heart problem. And we'll come back to that later on. So this is a case that actually illustrates, what we're going to talk about, and we'll try to kind of apply, these ideas and this knowledge in the context of clinical practice. So this is, a nice kind of quotes from, one of the authors in the field of enactivism, Canguilhem, who talks about, health as life lived in the silence of the organs. And this is an important thing that I want to start with which is the concept that, typically in a state of good health, what happens is our bodies are invisible. And we don't think about the bodies. We basically, as embodied agents, we sort of, that sense of embodiment, that sense of embodied agent is created very much through the direct interactions of, in our activities of daily living, in the exploring the environment, engaging with the environment and with others. And this is when everything is going well. So we can say we, sort of agents, we can do, our activities of daily living without any problems. And also, the sense of self, a kind of something that I feel well in myself, and I don't need to think about particular parts of my body. I'm not sort of aware of my neck. I'm not aware of my leg. Now, what happens is, we know this from practices, when pain starts, and physical, emotional pain, that will sort of shake a lot the foundations of the sense of self. And typically we hear patients saying this kind of and some of us have that experience, our bodies become visible. And that's an important thing to take into account, because how do we make them invisible again? So we can, and jumping a little bit from the concept of embodiment, we can think about, what's actually the role of the brain and the whole of the role of the whole central nervous system. So, the brains are do much more than just filtering and kind of making sense of the sensory information. And we will challenge during this presentation the sort of old concepts in cognitive science of, brains working as a kind of input-output machines, but actually, going a little bit further and sort of well beyond that sort of, outdated idea of sort of input-output. So the brains are embodied, they talk to the environment through the body. So this is important because, as osteopaths, we work, we treat the body, or we treat the individual, and sometimes actually we forget about there is an individual because we just focus on the body. But the body is an important part of the, of the whole interaction with our patients. And the brain, this nice kind of argument from Kirchhoff and Kiverstein, two philosophers very heavily involved in predictive processing models. They argue that the brain that is not embodied and embedded in the natural world would not be able to support this phenomenological, rich and detailed experience that we usually enjoy. So we can see here that the brain is critical, but the brain only, you know, the whole thing only makes sense in the context of that interaction with the environment, and, you know, and the sort of using the bottle to sample that environment and to make sense of what the sensory information is about. Now, I've said that, and we've seen that, you know, the bodies are typically invisible. What happens is, in the concept, you know, in the clinical cases, sort of complexity with body distress, persistent pain, and other persistent physical symptoms. And the context here of persistent physical symptoms in the literature is very much associated with, you know, medically unexplained symptoms, is associated with functional conditions such as irritable bowel syndrome, IBS, etc. So this, and other people call it sort of bodily distress syndrome. So there's a sort of, you know, a growing body of you know, of research literature around this idea of, you know, kind of persistent physical symptoms that are more than just pain, because, you know, have a number of other symptoms that tend to affect individuals. And what happens typically in those clinical scenarios, we know that the individual tends to focus a lot their attention on their body. And what happens is, and quite a lot of times, is there is a sort of a misinterpretation of those sensations as threatening causes of disease, of problems, and all of this creates a vicious circle, because, you know, what happens is that will increase the arousal, will lead to further attention on the particular part of the body. So that we kind of facing here a problem that requires a kind of a clever intervention that arguably goes beyond that, just kind of you know, fixing something wrong with the body, to try to understand the individual that actually lives inside that body. So it's important that we don't just talk about, you know, osteopathy is about bodies. Osteopathy is about individuals, and that's a very important you know, thing to consider. The other important aspects of, you know, the whole kind of experience and the sort of underpinning, you know, processes and so on, namely pain, is to understand that pain is not a sensation, and some authors argue that pain should be more viewed as an action problem, because pain tends to sort of, you know, when a nociceptive signal travels up, you know, from the periphery to the brain, it presents that brain with the question of what needs to be done. And clearly there are differences here between acute pain and chronic pain. We know that clearly in acute pain, there's very much, you know, an action problem in terms of protection, you know, what should be done, and typically the what needs to be done is protection. So we know that, you know, the nervous system, in a sense, is organized to anticipate that potential pain and is going to adjust behavior. And also we know that, you know, the whole, you know, all the regulatory processes occur in very much in a dynamical way at, you know, at different levels, and done in a Bayesian way, i.e. in a kind of a statistically meaningful way, taking into account previous experiences, how they are represented in the brain as predictions, and then the kind of estimates of likelihoods of what needs to be done in, you know, in a particular clinical condition. So that's a sort of, in a sense, you know, we can start thinking about here that, you know, there's something here about predictive processing that will, you know, we'll come back, you know, later. So clearly acute pain is different from chronic pain, and, you know, the talk here is largely about persistent pain and persistent physical symptoms and complexity. So we know that, you know, in the field of the neuroscience of pain, clearly this is a sort of well-demarked kind of, you know, let's say, geography of what acute pain is and representation in the brain. And we can see in this slide from Akparian and colleagues that clearly on the left-hand side, you can see the typical processing of acute pain, whereas on the right-hand side, we know, and this is from chronic back pain patients. We know that in the chronic pain, that sort of activation tends to be localized in areas of the, you know, of the cortical limbic system. So there is a difference here, and that is important to take into account, because clearly, you know, chronic pain is different from acute pain. We can't treat it in the same way, whereas acute pain, clearly there is a protection, there's a need, and, you know, patients should know that actually being in pain and having a muscle spine and so on, it can induce some kind of safety in me because it's protecting me from further damage. Whereas the chronic pain, it's a kind of, why? What is the reason for that? So the guys from the group of Vani Akbarian have come up with this idea that actually in the chronic pain, it's this concept that the brain became addicted to nociception, and that's very much the areas we know that are localized in the mesolimbic cortex, associated with areas of reward, and therefore it's kind of almost like a form of addiction. Now, the interesting thing, and if we move from that, those studies and those models developed largely from chronic back pain patients to other kind of clinical conditions that we tend to face, almost on a daily basis, some of us. This and the next slide are from papers published, this one last week and the next one this week. And here, it's an interesting one on chronic migraines. And, as you can see on this slide here, what the authors came up with is this sort of model that clearly shows that in recurrent headaches, what happens is there's a sort of, the pain is going to, it's going to disturb the pain and the reward circuits. And there's a sort of alterations in terms of functional connectivity. And as you can see here on the slide, on the model on the left-hand side of the slide, there's a sort of one important area here, which is the salience network. And we'll come back to that later on, particularly in the context of studies done now in osteopathy. So clearly there's something there that, the system sort of picks up as a salient kind of, stimuli. And also from their model, you can see there is a sort of, waiting for the pain stimulus. So there's a sort of an increased, highly intrinsic attention to pain that typically associated with the inability to feel pleasure. So the sort of alterations at the level of that mesolimbic cortex. And here we have to think about also there is a sort of dopamine plays an extremely important role, particularly in the case of, in the case of acute pain. Dopamine is important. That's a sort of motivational kind of, strategy. I need to sort of protect myself. I need to do something about it. But there's also associated with, or the lack of dopamine associated with chronicity. And in between episodes of migraines, what happens is, and they came up with this model that, the individual is waiting for, there's an expectation of pain happening. And this is actually similar to what happens with TMJ dysfunction, TMJ pain. And here we see with the sort of yellow dots, areas around the insular cortex and sort of interoceptive system, areas around, the salient network and the default mode network, extremely important in terms of the chronicity of temporal mandibular joint dysfunction. So again, what this is telling us that there's a sort of, there are kind of maladaptive changes in particular areas of the brain that are associated with the sense of self, the sort of interoceptive awareness, with the sort of reward systems, and something that follows kind of similar process to the ones where we can become addicted to something. So it's important to take into account because, the big question is, how can I change this? How can I rewire this? How can I change that maladaptive, neuroplasticity and make things slightly better? Is it enough just with osteopathy? Are there kind of other strategies that need to be used? Now, let's just look very quickly in terms of what we do as osteopaths. And this is, for some of you, is central to your type of practice. For others, may not be that important. But this is like, the typical osteopathic lenses, the 5 models. And some people say, I kind of focus on one or another, depending on my patient. Some say, the whole thing is very dynamic and they all kind of are all interrelated. Now, what we can see here is arguably most of these models are body-centered. I wouldn't call them just biomechanical or biomedical. I would call them body-centered. And, what we know is, apart from one, the behavioral one, that arguably is the biopsychosocial model. But what these body-centered models do not explain is the kind of experience of symptoms when there are no clear pathophysiological changes, when there's a disagreement between symptoms and degree of tissue damage, and also what happens in situations of placebo, but also situations of nocebo. And finally, what is missing from most of these models is the whole kind of social, psychosocial, and contextual factors that clearly are important in the experience of pain and other symptoms. In terms of the biopsychosocial model, one typical kind of argument that we can hear from osteopaths at times is that there's not enough bio in the biopsychosocial model because a lot of people consider that the bio is largely a biomechanical kind of issue, whereas the bio reflects, the whole biological aspect of the model. Now, this slide here from a paper from Joel, 2017, is important, and it's interesting to consider because what she kind of argues is that depending on the patient, you can navigate through the model in sort of giving more. In some patients, clearly the bio is the most important thing, whereas in other patients, clearly the psychological side is more important, that you kind of navigate the world this way. So it's not a rigid kind of models. Models are models, helps us to sort of navigate the world, but that's it. They're not sort of, they're not dogma. They're not sort of fixed, things that we need to kind of respect and do not challenge. And, a couple of months ago, we published this editorial on iJom, where we kind of, in a sense, we started the discussion about, models and the importance of kind of moving forward, the importance of challenging some of our preconceived ideas and so on. And we argued at the time that was important to take into account what's happening outside the profession and use that as an opportunity to move forward and to develop something that is robust and can withstand the kind of the fight from sometimes the other side of the barricades, and enabling us to have a strong argument. Now, the biopsychosocial model that as you know, is kind of extremely sexy these days, and a lot of people follow that model. The model doesn't come just, without any criticisms. And since the model was developed in 1977 by Engel, lots of things have kind of, have happened. And a lot of practitioners, a lot of authors argue that the model is hard to implement because something it can be extremely abstract. And last year, Stilwell and Harman published this very interesting paper that actually they kind of challenged a little bit the model and proposed kind of things that could be improved. And they came up with this, inactive view of pain as a relational and emergent process of sense making through a lived body. And that's a kind of, was a sort of an interesting thing to take into account and interesting to sort of to enable us to move forward. So, why I said, why do we need models? And models are useful, but arguably all of them are wrong, but they are still useful. It's as I said, they should not be dogma, but enable us to navigate complexity in a bit, in a better way. So let's think about, beyond that psychosocial model, and some authors have kind of argued that, to become truly patient-focused, we need to go beyond that sort of biopsychosocial perspective, and we should embrace this concept of symptom perceptual model that is underpinned by predictive processing. Those are, the arguments of, group of researchers from Belgium, Van der Berg and colleagues, but also guys from the, Ted Kapchuk lab in Harvard that, spend a lot of time researching, placebo. And, what they argue is really, what is important is to understand the patient and, understanding where that patient comes from, how is everything sort of generated, how is everything constructed. Now, it's clearly important to have an integrative model, and this is not just unique to osteopathy. And it's recently, a couple of months ago, there's a book published in psychiatry, actually proposing this sort of idea of an inactive model. And psychiatry is extremely interesting and very similar to osteopathy, because psychiatry doesn't really follow the typical evidence-based model, because it is extremely hard to implement a pure evidence-based practice model in psychiatry. And they have very similar problems that we face as osteopaths. So the sort of complexity, how do I best kind of, how do I support a particular patient? So starting from this kind of idea, actually important and take into account as a lot of these things, actually, the discussion already started in osteopathy, and one guy that was critical in that was Steve Tyerman. And, I remember the wonderful discussions I had with Steve and Hillary and other colleagues. Remember those discussions, and they were always sort of ahead of his time, because we always try to kind of bring these concepts from outside, a lot of things from the kind of work in phenomenology, sort of large in philosophy, and try to understand what's going on. And this idea that what is important is to think about that we are not isolated from the world around us. So the organism, the body and the brain and the world itself, constitute this generative model. And later on, when we talk about predictive processing, we'll talk about internal models and generative models and so on. It's important that we understand that the generative model is not just the brain, but is the whole, it's everything, okay? And this actually comes from guys like Carl Friston, which is one of the top researchers in the field, and clearly talking about this sort of concept of Unwelt and the sort of the importance of the interaction between the organism and the world, and sort of an embodied way. And the same from the guys, from Kirchhoff and Kivenstein, talking about the sort of, ideas of extended mind. Everything is about that interaction with the environment. And Steve Tyerman talked about it, as you can read, that the human capacity should be understood as, the individual capacity to engage with and act on their environment. So the sort of doing things that as agents we do. So, I'm an agent when I can easily sort of, do my day-to-day activities without any problem, without having to think about. And illness tends to sort of lead to a personal loss of agency. And that is particularly important in the context of chronicity. So at the end of the day, what's in it for me as an osteopath? And Steve, argued that the sort of one of the important things is to kind of help patients to make sense of their illness experience, creating new body narratives about what changed, the changing physical capacities and so on, how that impacts on their identity, the meaning of their lives and so on. So we can start thinking about here and seeing here an important kind of keyword, which is this idea of sense making, okay, which is the critical and central thing around inactivism. Inactivism is a sort of, also known as the 4 E's model of cognition these days. And the researchers in the field argue is that cognition arises from that dynamic interaction between the acting organism and the environment. And in a sense, the 4 important things here to take into account is that the mental processes are embodied, and here we're talking about the brain, the body, and the processes associated with that. The mental processes are embedded, so they function in a related external environment, are enacted, so they, the neural process, but also things that the organism does, and they're extended, i.e. they're extended into the organism's environment. And those are the sort of 4 key aspects of the, as I said, the 4 E's model of cognition from inactivism. Now, there's a key notion here, which is the notion of sense making, which is this sort of evaluative interaction of the organism with its environment. So it's, really, how does things, what is that thing about sense making? And from the book that I mentioned before, from psychiatry, this sort of, this is the five kind of elements here that are important to think about. Sense making is critical to living, and here we're not talking about just humans. We can talk about, we can talk about bacteria. We can talk about, an animal. We can talk about an animal that's, for example, might, and I've seen this picture of, it's a really fascinating picture of a squirrel sort of, top of a tree and looking at the tree, and you can see there's an owl there. But it's camouflaged, so you can see the sort of relationship, sort of sense making. Is there a predator, or is something I can see food? So it's a sort of that kind of element of trying to make some sense, and and with that there are kind of it's embedded in that environment and is embodied. That sense making implies values, and implies values from a metabolic perspective, but also values that go beyond the kind of metabolic things to kind of more existential one. And it's affective, so essentially it's a body affective evaluation. So it's important to start teasing out some ideas and sort of thinking about what is this thing about sense making. And at the end of the day, I would argue that actually that's what we try to do as osteopaths, and that's what what we try to kind of what we're developing at the moment, what the ideas we're proposing goes back, they go back to this idea of sort of sense making. So why is it relevant? Because the sort of things that can go wrong or can go well from that organism's perspective is always sort of rooted in this dynamic interaction, co-constitution of organism, parts, and the environment. So we can talk about the organism, the whole. We can talk about body parts as well, if you want to talk body parts, but you have to take things into that sort of a broader, more holistic perspective, if you want to call it that way. And we can't forget about the environment, and the environment is critical because that's how cognition is constructed in that way. So what, for example, Ungaro and Ward, in a very nice paper around an inactive view of placebo, because placebo is not being sort of explored from this perspective. Placebo not just about kind of expectations, but goes beyond expectations. Think about actually some kind of sense making. So they argue that we can't understand the body part in abstraction. We need to think about all these dynamics, because that can have an important role in terms of the health and the viability of that organism. So we can't take things into isolation. We can't just think about there's a little bit my neck hurts, and if you go back to the case that how we started this evening, clearly we can't take things into isolation. We need to think about the whole. And Clark, Andy Clark argues that the world is tailored for action, is structured by complex multi-level patterns of interoceptive, proprioceptive, and exteroceptive expectation, and is targeted by this attention and estimated uncertainty. So he has a sort of started making the bridge between this idea and the kind of what comes next, which is how does the brain process information. And I said before, clearly we need to challenge the ideas of sort of old, outdated ideas that we kind of operating on an input-output machine model, sort of cognition being very much that input-output. And I've been there. I kind of research during my PhD, sort of largely in cognitive science. That was the world. That was representations of memory and other kind of stuff, and there was everything was seen that way, and progressively people started challenging things, and it's interesting because the world became very much a multidisciplinary one. That's for example, the guys in neuroscience started talking to the philosophers, and that work between that synergy kind of really is leading to really interesting things. So the question is, can this idea of predictive processing being seen as sense making? The philosophers say so. Yes, that does have all the resources to cache this kind of inactivist checks, depicting the organism and the organism's salient world as bound together. So that's important, and also think about what we do as agents, as predictive processing enabled agents. We construct the world by sampling, but also we construct the world by action. And we're thinking here about is, it's not just, when we're talking about perception, it's not like we're passive on the sort of old idea of input output. We're not sort of passively waiting for information to process, to go upstairs and say, oh yeah, this makes something, sensation versus perception, sort of interpretation, in the higher centers of the cortex would mean that this is X or Y. Actually, action itself changes, and it changes everything and serves perception by actually constructing, arguably constructing the reality. So let's do a brief journey to, what is this stuff. So I'm not going to sort of bombard you with Bayesian theorems and complex equations. I'll give you some later on, but this stage is very much about what is this about. So important to start with the idea that really what we perceived is always this dynamic balance between top-down knowledge-based prediction and bottom-up incoming sensory evidence. And that goes beyond the kind of input-output, because here there is prediction, there is something anticipation, okay? And this predictive processing, if you look, if you look into the literature, is a kind of, it's growing, a lot in the last few years. And, you can find plenty of papers published already this year, and start sort of moving away from just philosophy, cognitive science, computational neuroscience, and so on, to start sort of making the bridge to healthcare, in particular mental health. And, what's, according to the theory, what happens is the brain is an homeostatic machine that is selected for making this largely Bayesian, statistical inferences. And the brain functions as a hierarchical, multi-level, this machine. And what it does sort of anticipates the distal courses of kind of internal and external sensory stimuli, with the main aim, which is to act to minimize the discrepancy, so the difference between my prediction and the signal from the received stimulus. So that's, that's what's going on. So, there's always sort of anticipation, there's always sort of, preempting what may happen, and try to compare, the sort of in a bidirectional way, the difference between my prediction and that sensory input, and see if there's an error, if there's a difference or not. And perception in this, according to predictive processing, is an active process, because what it does is, the brains predict and test the hypothesis against that sensory evidence, and you do this, and don't just react to the world. So they engage with the world, they change things, they kind of anticipate what's, what's going on. And this is done not an input-output, but is done as a sort of two-way bidirectional kind of inferences. And the two different levels, the sort of, what are regarded the lower levels of processing, then we can think about, from where the information enters, for example, you can think maybe the dorsal horn is the first sort of point of contact, but also to sort of primary cortices, like the somatosensory cortex. And so that's where the sort of, information here, not just from the outside world. So we're not talking about exteroceptive and proprioceptive input alone. We're talking about the interoceptive input as well, okay? And what happens is, when the sensory input does not match the prediction, those lower level layers transfer a prediction error up to the, to the upper layers. Okay, so, and this can kind of, will lead to change. So the sort of the idea of prediction error here is that it's the kind of it's the unexpected kind of signal. Okay, it's something that is not expected within the system, because it does not fit the prediction. And what happens in the upper layers of neural processing, and we can talk now about the sort of secondary sensory and association cortices. And apart from producing this, this generative model, this internal model, also what happens is, the brain predicts how the lower levels will change. And this is done in a kind of what is known as the prediction error minimization process. And it's important, if you read, for example, a lot of the work from Carl Friston around the concept of free energy principle is about sort of, we sort of always try to save as much energy as possible to stay alive, so we're not going to engage too much. Sometimes in very complex stuff, we tend to minimize that sort of energy, cost. So we try to minimize that prediction error as much as possible. This is just a representation of, we can think about, the predictive processing model, not this input-output, but this multi-level kind of system, and where things are kind of this bidirectional inferences are modulated and are processed at different levels of, in the hierarchy. Okay, so we can think about, where is the information going to, where, how is everything sort of processed, where is everything kind of modulated, and so on. So within this system, I mentioned that, the main goal is to minimize this prediction error. And in a normal functioning brain, those prediction errors typically minimized in 3 ways. So the prediction error can be propagated back along the cortical connections to modify the prediction. So the prediction is sort of the internal model, your hypothesis, if you want to put it that way. The incoming thalamic input can be modified by moving the body, and this is important because it leads us to sort of the concept of active inference as well. So it's, everything is very active. And the other thing to think about is, this sort of the brain intrinsic and widely distributed cognitive networks can change the focus of attention by biasing the influence of incoming sensory input. So here there's a sort of a, how do I minimize everything? Actually, things are done in a kind of a weighted, precision-weighted way. So, if everything is functioning well, actually, I kind of, I try to be as precise as possible in my prediction, in the minimization of that prediction error. So it's not just by chance. It's not like, kind of I can't be bothered and therefore, anything goes. No, it's a different way. It's done really in this sort of, precision weighting kind of way, which in the typical kind of world of cognitive science was previously known as attention. But actually, that's the attention in the part of the predictive processing model. So I mentioned before that, the free energy principle, which is kind of an interesting, can sound a little bit complex to start, because talked about Markov blankets and so on, which is basically divisions between internal and external environments and so on, which kind of mathematical models. But at the end of the day, it's all about avoiding uncertainty, and what it does is the system, to reduce surprise, uncertainty, can actually use action to reduce that free energy, so the prediction errors, by changing sensory input. And this is important because actually we'll see this later on. It does explain sometimes why patients in particular situations actually kind of can create their own symptoms, because actually the system is trying to kind of minimize that prediction error and actually actively change it. So you can see this picture here at the top, kind of perceptual inference. So kind of information, for example, extraceptive stuff from vision, sort of compare different levels and so on, and then it's propagated along the kind of network to higher kind of, levels of the hierarchy. But the other stuff can also happen. So I can actually, by moving, and I can move also, by sort of saccadic movements, is the same thing. But, through movement, I can actually kind of change the whole perception. I can actually change the whole kind of experience. And this is exactly how the kind of homeostasis works, actually. So, predictive processing explains a lot, this from a sort of allostatic perspective. So let's just, before we kind of move on to other stuff and move to clinical practice, just a couple of things that actually illustrate this sort of predictive processing in action. One of the things is typically through illusions. So some of you, if you know this picture, therefore, you look at this and you can see, a dog in the middle, okay, so a Dalmatian. If you don't know this picture, it goes through the process very much kind of, it's sensory information. You try to make some sense of this, and, it's hard, and you may not make any sense, but you actually haven't got that much of a prediction. It's sort of already built in, so it's difficult to compare, kind of minimizing some prediction errors. So you can actually see this, and through a process, you could get to a point, say, yes, I can see that. And when you see, you have this aha kind of insight moment, almost, that's, in a sense, is a sort of a revision of your internal model. Next time you look at this picture, guess what happens is you can see this straight away. You will focus in and you know this. The second picture, second illusion, is a similar kind of thing, so you can look at this and spend plenty of time, and you can see dots and black and white here. But if you know the picture, you can see a cow, and the cow is looking at you. Okay, you can see at the bottom of the picture, the kind of nose, a little bit high up, the ears and the eyes, and you can see that the cow is directly looking at you. Again, through this process, you can think, how does this make sense? May not make any sense because you haven't seen it before, but once you sort of revise the internal model through this sort of process of, incoming sensory information, you kind of, your prediction error will violate your model sometimes. I don't know, this is like black and white, and suddenly you can see, no, there is a cow, I can see the cow, and, of course, you revised your model. It can also, the illusions can go, can also give you kind of some proprioceptive kind of sensation. So, for example, for some people, this may sort of give you the, vertigo, because, it's kind of it's pretty high, this stuff. When you actually look at the second part of the illusion, and you can go online and look for Scrappen illusion, and it's pretty cool stuff. And I use this, with sort of as a tool for pain education. You can actually see in the second picture, I'm not scared of this, and because I know this is just it's a picture, it's nothing else, and it's actually not real. So illusions sort of tell us a little bit about this, but also you can can think about some auditory illusions, and we're just going to show you this very quickly. It's a very quick video here, so bear with me. Well, let's put this at the beginning. Okay.
The man read the newspaper at lunchtime.
Okay, so this is, go back, sorry guys. So this is another example, is an illusion, and you clearly see, the first stage, if you never come across this, it kind of does not make any sense. So you sort of try to make some sense of that information, but, may not make that much sense. When you actually hear the second time, and you go back to the sine wave speech in the third one, actually you clearly, it's the same sound, it's the same kind of construction, but actually you've got, now you can understand why, because you've revised the model. Now you've got a prediction where you can compare against the sensory input, and you minimize in the second part, you minimize that prediction error by your prediction is pretty strong. Yes, I'm pretty sure they're saying this. Whereas before, you didn't have that kind of, let's say, templates that you could compare the information against. The illusions, and again, on the predictive processing, go beyond this sort of extraceptive, proprioceptive stuff, and so on. You can talk about, rubber hand illusion, and the sort of the sense of embodiment and body ownership. That's in particular body ownership. That's the illusion kind of explore. So these are kind of shows that our brains very much constitute the mental life is Bayesian, and the predictions constitute these internal models of the body in the world, and how they're constructed in this sort of Bayesian inference. Okay, which is sort of has to deal with the sensory inputs. And then sort of compared with the sort of the predictive model, the internal model, the generative model that exists, and that's where from Barrett and colleagues argue that is from which all perceptions and action occur. Other guys, and there's a number of guys, came up with this this kind of definition of perception being controlled by hallucination. Some of you may have seen a brilliant talk by Anil Seth on TED, which actually talks about the same thing. And actually you can see, that some of the stuff I've just gone through is kind of, it touches that, in a very clever, very good way. Okay. So predictive processing is it just about cognition? Is that all? And no, it's actually, the big argument is that, of course, is important in constructing cognitions, emotions, perceptions, guides actions, and so on. That's critical because, that's our life as agents in the world, in the interactions with the world, and so on. That's pretty relevant. But actually, the whole architecture for prediction evolved not for these purposes, but actually to implement allostasis. So it's about sort of efficient metabolic and energy regulation. And we know that actually from some of the kind of structure and functional neuroimaging studies that actually, there's a system that is at the heart of this, that it's very important, from a predictive processing perspective, and very important from an allostatic regulation perspective. And those are the kind of, default mode network and the salience network. Again, going back to where we started today, talking about, pain, talking about, TMJ dysfunction, talking about migraines and so on. And you could see, and we'll go back to that later with the osteopathy, we can see that stuff plays a very important role. So allostasis, interception, is sort of a critical aspects of the predictive processing model. So we can think about, again, what's the relevance of all this stuff from a clinical perspective. So it's about, actually core principle of osteopathy, isn't it? It's sort of about the regulation and so on. Okay. So we can see here that's, allostasis is not a perceptual thing, sort of passive stuff, but it's actually an active inference. So the body changes actively. So the brain predicts about what is about to happen in the external and internal environment, and then predicts the best course of action. So it's kind of it's always anticipating what's going to happen in the future. So it's it's not a sort of passive recipient of information, say, okay, what should I do? But actually, it's about predicting the future. So that's a sort of, a very important thing to think about. Allostasis is sort of active inference, changes, is action, okay? And then we need to kind of think about that. So, all this stuff, if you think about, okay, so I had my new prediction is imagine the sine wave, or the kind of or the cow, illusion and so on. So, my new prediction, I hadn't seen that stuff before, or maybe I had, but, I wasn't entirely clear about, sometimes you have illusions, you can see 2 or 3 different things, and maybe you could see, you in the past you've seen 1 or 2, and now you can see the third, for example. So your old predictions could be, okay, yeah, now there's a cow there, maybe there's something else. And then you're faced with the information that is about the kind of the learning rate and the prediction error. It kind of looks like a complex equation, but actually it isn't that complex, okay? So what equation, it's not just about, we need to think about that stuff. So it's not about new prediction is old prediction times prediction error. No, it goes beyond that, because, I talked about before this concept of attention, this concept of, precision weighting. So I need to think about really, how do I minimize that prediction error? It needs to be a process there. And the process is about sort of taking into account, the kind of the prior precision, how much is already know, the likelihood precision, which is about, how much is learned from the current sensory input. And, the bit in the middle is the weight, which is the learning rate, which increases the likelihood and the precision and decreases the prior, with the prior precision. It's kind of, it's complex, is mathematics, but it's just to try to illustrate the 2 things. One important thing to take into account here is, any new prediction is old plus the kind of a weighting process, plus the sort of, needs to be, I need to weight the information times the prediction error. The prediction error here comes from the sensory input, and you can think about proprioceptive, interoceptive, and exteroceptive sensory input. Or you can put it in a very simple way, which is, when the priors are pretty strong, i.e. the prediction, they have a greater weight, and the precision, precision weight goes to the side of the precision clearly. That prediction, that prior is going to dominate the perception. Whereas other times what happens is the other way around. Actually, the sensory input is much stronger than the prior, and again, this sort of process of what's going on and so on, in a kind of a calibrated way, the sensory input is going to win. Why is this relevant? We'll see that actually this happens in clinical practice a lot, and actually that's the argument here. That's the beauty of the whole thing, and try to understand what we want to do. Why are you telling me about predictive processing? What's in it for me as an osteopath? So why is it relevant? Clinical practice is typically characterized by complexity, and the patients that come with, like the 37-year-old that we started with, don't just come with a simple thing. They come with quite a lot of stuff, a whole baggage, and arguably, a lot of those patients are not suitable for, call it biomechanical alone, biomedical, body-biased models of care. Some people say, yeah, okay, great, and they're suited for the biopsychosocial model. Yeah, great, absolutely, probably, yes. But maybe there's something else we need to think about, and maybe we can make it more personal. Maybe we can make it, the big argument that we don't treat the conditions, we treat them pretty much the individual. So like we start, before I argued, didn't argue that a couple of authors argued that we need to go beyond the biopsychosocial model to think about this sort of, symptom model and think about the individual. So some guys have started making, some noise about, around the predictive processing and clinical practice. It started sort of, there's some first touches around pain, clearly on mental health, several kind of papers published around there, kind of interesting things. So the interoceptive, for example, the interoceptive prediction errors, the sensations come from the inside. A lot of people kind of think about, this sort of, are kind of the sources of anxiety, but actually, arguably they are more than sources of anxiety. They drive autonomic, metacognitive, allostatic systems and so on. And, arguments like in the case, for example, of depression, the way CBT treatments, for example, work, according to Lisa Barrett and colleagues, is, they enable the individuals to construct new concepts that, as prediction signals, modify the gain on prediction errors via the salient network, i.e., that kind of new input, that unexpected input, becomes very salient input, that it will have the power of violating. So we're thinking here about really, how do I violate my model? How do I violate my internal model? Or actually, how do I violate my patient's internal model and kind of move forward, how can I do that? And it's actually modulating from a kind of a neuro perspective, is sort of happens at the level of the salient network, i.e. picking up what's salient, what is important, okay? So, and that's what's, that's important, and we need to think about that. And the other thing is, from a symptom perception perspective, we need to think about, things are always contextualized. They vary a lot, within person and within situation. And, it's interesting kind of argument that from Ongaro and Kapchuk, that we feel pain because we predict that we are in pain. And that's based on integration of sensory inputs, prior experience, and contextual cues, okay? So, for example, going back to the kind of, you saw the pictures, the model around migraines, that, chronic migraine sufferers are kind of waiting for, when is this going to happen again? So it kind of, you can think about, sometimes it's enough just that sort of heightened attention to it, that actually we can predict that you're really in pain, and actually the whole thing becomes true. So yeah, there's a construction, there's the sort of mental construct of the whole thing. But are you going to tell the patient, oh yeah, that's in your mind, that's upstairs, that's all in your head? That's very personal. That's very personal. Each one of us will construct our own reality. So clearly, in this model, you can see that the sort of predictive processing plays a role, but actually, there's a kind of other stuff that needs to be taken into account, and those are considered moderators. And those moderators include, gender, for example, but also the sort of low interoceptive sensitivity, for example, and that's important. Again, you find that in the literature, for example, chronic pain sufferers tend to have low interoceptive accuracy, and one of the arguments for that is that the system is so saturated with information that actually you learn how to block some of the. You don't want to kind of get more information. Some people say that having being too accurate, too aware of your kind of what's coming from inside is actually bad as well. Yeah, it's associated with some clinical conditions, but it's important. For example, you find that's a sort of link in acute pain with high interoceptive accuracy, and that's actually important because linked to the kind of a salience network, and you think about dopamine and so on, motivates you to sort of to protect, to do something about it. So it's kind of there's things that can be bad, can be good, but actually the moderators on the whole model. Then you can think about, okay, what about pain protection and so on? So from this perspective, from this sort of free energy model principle, you can think about, persistent pain in patients with fear of movement, with kinesiophobia. So, for example, you could argue that the protective mechanisms can be related to movements initiated to reduce prediction errors and confirm existing predictions. So I can have a prediction of, if I bend forward, if I go in lumbar flexion with my chronic low back pain, that I will have pain. So therefore, the prediction is pretty strong. I can start the movement, and actually with a sort of a minimum, the minimal kind of movement, a minimal input could be enough for me to actually, through active inference, by actually kind of validating that prediction and actually being sort of say, I can't move more because I'm actually already in pain. So that can happen, kind of the system can produce that. The system can become extremely good at sort of, at minimizing that prediction error, doesn't want to really change that much. And we need to kind of, how do I change this? Well, probably through some graded exposure is one of the ways, but actually that's one of the things. So I think that way we can think about, this sometimes happens a lot in the context of placebo. And actually this is from a paper on placebo. So, the argument here that the whole kind of medical ritual is going to prompt the brain to interpret even very small interoceptive changes as the consequences of healing. And therefore, if you're in the good hands, in the right place, and you've got the right practitioner and everything goes well and so on, and very much what you're predicting kind of fits nicely with the kind of incoming information, through active inference, actually you can start producing some changes. Some changes could be changes at the level of kind of relaxation, for example, of the stomach muscles and sort of noises and so on, that some of us would say, right, kind of that's the autonomic nervous system happening, working, doing great stuff. Absolutely. But, from this perspective is, there's a prediction. This will lead to something that is, it's going to feel great. It's going to lead to sort of an improvement in my condition. And actually in the right way, in the right hands and so on, the system is already changing through, we talked about allostasis is active inference. So we can start sort of predicting the future and you can start modifying things, okay? Just a quick thing on this slide, not going to spend too much time, but for example, in abdominal pain, you can think about, for example, you've got this sort of prediction of, if I've got, this kind of sound, I might have abdominal pain. And there's a kind of several possibilities here. One of the possibilities, through active inference of maintaining the pain is, I have, I've got a few interoceptive signals coming from inside, don't feel great and so on. I touch my belly, I rub my stomach, and actually that might simply, start the whole process. So I can, actively being very good at sort of producing and maintaining the symptom. Or it could be the other way around, which actually I create a surprise in the system, which I've got this, but actually I did not develop pain. So you can think about that. Actually, in that case, the prediction error, it's greater than the prediction itself, and you can sort of validate, update the model, and next time you actually don't associate a minor signal with the start of pain again, and so on and so forth. Other thing, what about good pain? Good pain is an interesting one. We could sort of argue that it's also associated with this, because how come that good pain is therapeutic and is good? I guess you could argue good pain is associated with the reward. So yeah, maybe there's a sort of a big shot of dopamine as part of that. Absolutely, but you can think about where is the source of the noxious stimulus is actually from the clinician, and that it's kind of painful, but it feels kind of good because I know that I will feel much better later on tomorrow, or over time. So people are kind of sometimes prepared with that, and instead of kind of engaging this sort of low-level motor reflexive responses, actually what it does is it kind of engages allostatic changes, which arguably under the form of some updated beliefs about the safety and tolerance of those nociceptive inputs, and leads to an improvement. So even good pain could be kind of interpreted from this lens. But again, we may have in other patients when there's a sort of a lot of kind of emotional, cognitive factors and so on to take into account, depressions, anxieties, and so on. That's the experience of that nociception is actually the other way around. So we have those patients that minimal contact, minimal, they anticipate, they feel that this is painful, therefore there is damage. Or when you prescribe an exercise, for example, the patient does the exercise and comes back a couple of days or 3 days and say, the exercise you gave me, I'm much worse than before. Because, even just DOMs that are absolutely normal if you haven't exercised for a while are interpreted as kind of validating the prior belief that is, okay, this equals damage, and therefore I'm worse than before. So, it's kind of the fascinating thing with this is kind of the way I see it is it's to understand each patient as a patient. Actually, honestly, it can be quite a lot of fun kind of try to go through that and try to kind of I'm always with this idea, how can I surprise the system? How can I violate their expectations? So the expectations here are important. Remember the case, we started with that case. There's a kind of, I've been to the doctor and so on, something might be wrong with me. So there is, expectations. We know that in the context of expectations, cognitive reassurance is an evidence-based intervention. Plenty of evidence supporting, for example, in case, musculoskeletal care, for example, low back pain and so on. However, reassurance may not work for everybody. So this is a model that actually tries to understand that, the role of expectations in the context of, more complex conditions. So we have kind of a symptom perception here at the top. There's a general concern, so gastrointestinal kind of complaints. I could have a serious medical disease. Treatment setting, we go to the doctor says, okay, will tell me what's wrong with me. The doctor may tell you, what, I've done all these tests and there's nothing wrong with you. And, you can have, this is two-way system, this is, it's kind of two avenues, let's say. One is a sort of, expectation, update. Great, nothing wrong with me. So kind of cool, nothing to worry about, move on. I was so concerned. Actually, the patient comes back a week after and say, how are you doing? I'm so much better, but I didn't treat you last time or did minimal intervention. Yes, but you told me that I don't think, I've got anything wrong with me. But of course, you've got the other guys. And the other guys are the guys that, like the first patient, the patient, the the 37-year-old, which is, yes, what if? What about if what about if someone has missed something? And this leads to kind of some cognitive reappraisal and so on. So you can continue kind of searching for an answer. And this is just a sort of maintaining that expectation and so on. So the question is, how can I short circuit the whole thing? And you can see in this model here, which is kind of tries to put the two things on a predictive processing perspective. Clearly, there's a sensory input and there's the expectation. We need to think about the two. We can't just think about his touch and do movement and so on. We need to think about what's going on higher up in upstairs in the box, and what is the kind of what's the power of that, and how do I change that? So sort of can think, oh yeah, this guy is going towards a kind of psychologically informed style of practice. Yeah, I guess so. But it's important to take into account, because that plays a role in the kind of some chronically disabling conditions. So bottom line is, why is this relevant? What's the goal? So the goal here, and that's the kind of our argument is, the goal is about sort of it's about causing a positive surprise with a high prediction error that is going to violate the existing predictions, and then sort of validate the internal model. So that's the way, it's one way, it's one lens of looking at the patient, particularly the complex ones. Try to understand really, how can I surprise the system? How can I kind of, patients say, oh, I wasn't expecting, actually, I feel a little bit better, and so on. Sometimes, you surprise yourself, but, I guess that's a sort of a two-way system, really, working in synergy. I mentioned that, the literature is growing, and this is from mental health, but very much applicable to what we do as osteopaths. And you can see this sort of model here, from a symptom general perception and from a predictive processing. So it's about understanding persistent physical symptoms. So a lot of osteopathy here for sure. The hierarchy. So you've got the lower levels of the predictive hierarchy, and here the interoceptive stuff plays a very important role, the kind of beliefs, the embodied predictions, and so on. And then the higher levels of the prediction hierarchy. And this is about sort of beliefs about being healthy, reassurance, and so on. So you need to think about, putting the two together, kind of the stuff coming from inside, the interoceptive, the proprioceptive, the exteroceptive input, but also think about, what about the stuff that is upstairs? What about the kind of the belief system, the priors, the predictions? The others also have predictions, but this is a sort of a different thing. And you need to consider both to actually do a good job and understand the complexity. So, as I said, this is all kind of developing and so on. We're very much at early stages. Hopefully in a few weeks, we'll get some stuff submitted to be grilled by some guys and see where we're going from there. So it's kind of exciting times, I guess. So I talked about kind of equations. Okay, so the equation, I've presented before. It's very much prediction plus the kind of learning rate, the precision weighting plus, prediction error equals the new prediction. Now, what about in osteopathy? Well, the kind of interesting thing here is I can't just think about osteopathy as a one-way kind of system, because, what you've got is, and there's a beautiful paper from 2015 from Oberg on the kind of, kind of inactive embodied sort of, sense-making stuff in physiotherapy. And she talks about dyadic kind of interaction between a patient and the practitioner, because this is when the two become one kind of thing. That is that dialogue, okay? And in that dialogue, I can think about the prediction of the patient. So which is, you can pick up all that stuff, all prediction, learning rate, prediction error, and so on, shove it into the prediction of the patient, plus the prediction of the operator, because the operator comes with his own baggage and his own sort of, belief system and so on. Even on the day, I can think about, patients may be complex and I'm surprised. Oh, okay, how did you improve? Or why are you not getting better? So how do I feel on the day and so on? So that's important, because the two together, kind of then divided by the learning rate, I think contribute to what we do. And And the other day, sort of, Francesco and I had a sort of fascinating talk around this equation. And it was interesting because, we were talking about how do you surprise the system, and the surprising the system could sort of mean here, you can surprise the system in a very quick way. Example, high velocity thrust. The guys say, yo, that feels so much better. Okay, so there's a sort of clearly an interaction here that led to that and so on, the belief of a patient plus the operator, everything goes well. And here you can put the context and everything, it's the whole package is inside that equation. But also you can think about, what about the other stuff? What about if you decide to do a kind of biodynamic approach that, you looks like you're not doing anything really. And the argument could be actually, you might not sort of get the immediate surprise, but you might get the surprise in the long run. The guys sort of say, comes back and say things are getting better. And actually, arguably, this sort of long-term kind of thing could be sort of explained by the system picking up what's salient and start sort of changing, sort of, surprising itself. So, this is kind of speculative, but that's the whole thing about anyway. So it's just trying to kind of come up with something clever. So as I said, need to get this out to be trashed and further developed, I'm pretty sure. So how do you do this? Okay, so it's not about hands-on alone. Arguably, it's about combining kind of hands-on treatment with some good reassurance, with language, with graded exposure to movement, and so on and so forth. And the other paper we have, also working with Hilary, is on trying to understand, the kind of from the UK OsteoMap model, sort of seen from this lens. And actually, we sort of had some fascinating kind of data there from patient narratives that actually kind of fits very nicely this sort of developing model. So we kind of, we started talking about how, we're surprising the system. And clearly here, in that particular model, it's not about osteopathies alone. It's about sort of the acceptance commitment therapy kind of approach, the mindful kind of way, and so on. So the whole thing together seems to work. Now, how this works, arguably kind of updates the internal model, reduces activity in areas such as amygdala, basal ganglia, cerebellum, and so on, and achieves allostatic regulation. That's the kind of argument from outside osteopathy, but kind of makes sense, I think. Language is critical here, so we need to stop telling people what's wrong with them. Okay, so I think it's very important that we tell them what's good with them. So it's so people can kind of become, improve their agency, becoming sort of more, think about the resilience of their bodies and so on. Use images and metaphors. So images here can be pictures, can be the illusions, and I use them, but also images as kind of visual images, sort of. Whilst you're touching, whilst you're treating, whilst sort of, think about this, focus on the sensations. The language is an important part here because this is sort of the two things together. It kind of, I think they potentiate each other. So if you remember the case, the whole thing about, wear and tear, kind of, she was worried and so on, did several tests. And in fact, what happened with that particular patient, she was, after, I think 2 or 3 sessions, she was feeling much better, but she still had some discomfort around the left breast, and she was quite worried about that. And she decided, well, I'm going to have another mammogram done because I'm really worried. And in fact, she had it, and she came back, and actually the whole thing improved. So clearly, she needed further reassurance. Now we have some patients which are kind of are known as being, suffering from cognitive immunization. You've seen before on that Vilex model that basically what happens is kind of you keep reappraising the information, and you get to a point you just sort of, you're just going on, and you go to Dr. Google and kind of further, confirms your idea, and you become cognitively immune to change. So that, we need to make sure that we prevent patients from negatively, reappraising normal test results. And this can be done different ways, and can be done, for example, before you conduct, for example, an examination. I'm going to do a neurological examination, and if I, expecting to, if I find X and Y and Z, this equals this, normal. And kind of, reiterate that message, pass that message to the patient, and sort of, if you get that kind of finding, really say, you know what, this is it. So it can help, but also we've got the kind of hands-on stuff. And, Aya Lederman kind of thought-provoking kind of masterclass a few years ago argued that the hands, it's not just about, correcting somatic dysfunctions and so on, popping stuff back in place and so on, but it's about kind of delivering touch effects and positive effects on the sense of self and so on. So the question is, is this about specific or non-specific effects? And the question is, does it matter? Now, a couple of studies that's from our group, from CAM Collaboration, from Italy. So a couple of neuroimaging studies. I think the two first in osteopathy, and as far as I'm aware, there's only one in manual therapy done. And this one, Tamburello and colleagues developed, last year. They were looking for somatic dysfunctions, this evil word, okay, that I'm critical about, but, they looked for stuff, they found stuff, and they treated, and they found that, after treatment and so on, there was sort of clear kind of changes in activity in areas of the posterior kind of cingulate cortex and so on, sort of part of that central autonomic nerve network and so on. Their argument was that, what the treatment showed was the sort of sympathovagal modulation, as the osteopathic treatment. Important bits here, stuff on the kind of salience network, central autonomic network. So kind of some of the stuff goes back to, where we started with pain and so on. Francesco's recent study from his PhD, he looked at patients with chronic low back pain. They were, they were kind of imaged before and after treatments, and after a few treatments, they saw kind of a clear kind of changes in activity in areas related to interoception, as such, such as the bilateral insula, the anterior cingulate cortex, left striatum, and the right medial frontal gyrus. Again, some bits here in the salience network. So it seems like the body starts sort of giving attention to some signals. Remember when I was talking about the equation, it could be that, gentle treatment. And by the way, the treatment here on this particular study was all indirect, with BLT, with biodynamic approaches and so on, so cranial and so on. So, for those that kind of argue, well, where's the evidence for that? Maybe it works, but it works in a completely different model. That's a paradigm that we believe it does. But it kind of, one of the arguments is, along the lines of that equation, maybe this led to kind of a change in the model, in the internal model over time. So patients also became, improve on their interoceptive accuracy. So they became more kind of more sensitive to the information coming from inside. And, the argument here is maybe with osteopathy, we're talking about the kind of interoceptive paradigm rather than, pure exteroceptive one with kind of, proprioception and so on. Stuff about being specific or not, this study from last year, manipulation of, lumbar spine for guys with back pain, target spinal level, kind of, I found a dysfunction, I treat the dysfunction versus I just do a non-specific HVT, and the results were the same. So, maybe it's about the thrust, maybe it's about the changes that it causes, who knows? But maybe it's not just about, correcting the dysfunction itself that is the most important, but it's about the sort of what other guys outside osteopathy, manual therapy talk about. That's, paradigm for understanding, manual therapy is about the sort of, it's a neurophysiological one, kind of I would say neurophysiological, psychological one. So the sort of the hands-on, the touch, and we argued, a few years ago, 2017, this paper, we put together a hypothesis paper around perinatal care, but this goes beyond that. We can think about, adults as well. The kind of touch as affective touch, this sort of CT fibers, and the two different types of touch, the kind of what we know about the discriminative sensory one going to the somatosensory cortex and other bits, and the other one, the affective one, traveling up into the insula and so on. So it seems like, the gentle stuff goes up. And we proposed at the time this kind of insular homunculus that does have a big representation for example, the upper back and the head. And this is based on, a number of studies. We kind of came up with this hypothesis. So we know that kind of works, affective touch outside the clinical practice, experimentally, does modulate pain. We also, from the studies we've done with preterms in Italy, that, for example, experimentally, just comparing dynamic touch with static touch, the dynamic touch delivered at particular temperatures, particular velocity, and so on, led to changes in the autonomic nervous system on those preterm babies. We also, there are other studies from other groups that also show kind of similar kind of effects. It seems like the touch itself kind of works. Beyond touch and language, I think, this is where interventions such as the osteomap work well, or the psychologically informed practice works well, is you kind of, graded exposure to movement, to interoceptive kind of exposure and so on, opportunities to kind of start thinking about stuff and so on. Okay, so it's coming to an end. It's a couple of slides and then we're done. Sorry about this long presentation. It's always long. Talk too much. So developing ideas here, sense making in osteopathy. And this is a very kind of very underdeveloped guy on the left-hand side, a kind of the agent interacting with the environment. So it's a sense-making guy. It's an activist kind of patient, clearly underpinned by some biopsychosocial kind of ideas and the predictive processing there in the middle. The equation that we kind of argued. And then let's think about, two things, one kind of, mainly sensory thing, and the other one where clearly the predictions play a role. So you think about, why does it work with the preterms? The preterms don't arguably have a prediction about, there's an osteopath, there's a guy coming, he's going to touch me, I'm going to feel great. Actually, this picture here is from a paper that we just got accepted on Frontiers in Pediatrics, and is a model for assessment in a kind of in neonatology, a manual model. But actually, what we're proposing there is, the osteopath touches the baby and there's changes, and we observed from the study we ran published last year that those changes, the touch itself leads to kind of some allostatic regulation. So it seems like, taking into account the body is the first prior. And so we can think about maybe sense making. This case is about allostatic regulation. It's not about kind of, this is going to be good. But if you think about sense making in chronicity, okay, and this is from the other paper we're working on, we can argue that, we can help patients make better sense of persistent physical symptoms and create personal, sustainable ways of managing their own health and well-being. And this is about combining a therapeutic attitude, communication, mindful approaches to touch, movement, and so on, and a kind of psychologically informed type of practice. So it's a sort of a full package, and that's how we kind of, I guess, surprise the system. But it's going to take a while. It's some of this stuff will become, salient kind of bits that will, rewire things in the long run. It's not going to change overnight because the maladaptive neuroplasticity took a while to kind of, to happen. So it's a kind of a model of learning, self-discovery, and so on. It's about helping people reappraise maladaptive beliefs, predictions, and so on. Okay, taking into account, the kind of what we call the cognitive immunized guys, and some guys are cognitively immunized against educational reassurance. There's some guys, here we go again, he's going to give me a lecture on pain neuroscience, for example, or he's going to tell me that, nothing to worry about. It's like, I remember a patient when I was in Dubai 2 years ago, explaining the patient, it's nothing wrong with me, with you, and so on. So try to reassure, silly me trying to kind of make some sense of the world for the patient. And the patient say, oh, it's nothing wrong, so amen, right? So why do I have the symptoms? So, you know, you clearly, you think sometimes you think, oh, just being stupid or what? You know, why is this guy not listening? But clearly it does not make sense to some of them, or they're kind of immune to stuff, okay? So to finish, you know, we're thinking about, you know, I like this quotation from Andy Clark's book. So if you kind of want a heavy or not so heavy kind of journey to predictive processing, you know, read Surfing Uncertainty. So the brain is it's a restless, proactive organ locked in a dense, continuous exchange with the body and the world. So clearly here, we're not talking about, you know, predictive processing just as in brain. We're talking about body, we're talking about the world. So going back to the sense-making framework, the enactive kind of framework, and then, you know, equipped with that stuff, then we're going to sort of encounter through play of self-predicted sensory stimulation, a world of meaning, structure, and opportunity, and is a world parsed for action, pregnant with future and patterned by the past. So this is it. And so I hope to kind of made some sense, and happy to answer some questions. So the idea here is, as I said, this is like something we're proposing. It's not kind of our model or nothing else. It's a model. I hate kind of models. It's a framework, okay? And it's just kind of, you know, it's just think about stuff, okay? So remember that all models are wrong, but some are pretty useful. And this is the team, you know, small team at the moment. It will grow, I'm sure. But, you know, it's a kind of core team, you know, we're working on this stuff. All right, guys, so please, I'll call, I'm not sure if Francesco is in, I'll call Hillary to join us. Hill.
Hi, thank you very much for that marathon, George. I'm amazed at how many really complex research papers you can cram into those slides.
Yeah, I'm a bit autistic, I guess, on this stuff. Never mind. Hey, I thought about doing a 6-second PhD, but I can't be bothered. No, I have no patience for that. No, it's this is the COVID-19 kind of stuff. So you have nothing else to do. See patients and do stuff. Okay. So have we got, you know, we had a question here before. Oh, yeah. Annette, does that predictive coding equation mean that we can use treatment factors to increase the likelihood precision? Yeah, absolutely. And that's what we try to kind of think about, you know, that dyadic kind of thing, you know, so it's the relationship. And actually, you know, that's the critical part of the osteomap. And actually, you know, Hillary could perhaps say a little bit about that, sort of the importance of that interaction and how that is, it creates that sort of, you know, weighted precision of what does this mean to me, isn't it?
I think in terms of Osteomap, and I don't know how many of you are listening are familiar with it, so just very briefly, we did a project between 2013 and 2016 which was aiming to integrate psychological interventions from a thing called acceptance and commitment therapy, which is a form of CBT, and mindfulness with osteopathic practice, delivered by osteopaths, not by psychologists, with individual patients, in order to help people with chronic pain to live more active and fulfilling lives, even if their pain didn't go away. There were people that we know benefit from osteopathic treatment, but never kind of get fixed and leave us and go away. And our aim was to help people to understand themselves more and reconnect with things that mattered in their lives. So we were really interested in their social context and their sense of themselves. But we went into it, I think, fairly naively, not quite sure how we could crash together psychological burbling with our hands-on assessment and treatment. And we kind of fell across this stuff by accident, because it seemed to be that in terms of the context, creating a safe therapeutic space between the patient and the practitioner where they knew we were really interested. We went very gently with them, that it was a trusting space, and we were encouraging them to be curious about their bodies and how they could use them maybe differently, not the way they had worked once upon a time. Made some sort of opportunities for us to change their frame. Didn't know anything about predictive processing, none of this neurophysiology stuff, but we began to notice that there were transformational changes that happened just sometimes when at the end of a session a patient appeared to have totally altered the way they felt about their pain, or they went out in a bit of a state and they came back the next week having had some miraculous change. And it seemed to be around that sense of interoceptive surprise, that they were expecting something to be painful or difficult, and somehow, because of the way that we were working in this very curious, safe sort of way, there was an opportunity for them to notice that what they were sensing in their body wasn't what they were predicting that was going to be really painful or horrible or difficult. Mm-hmm. And that was the thing. It was far more strong, I can't think of the right word, strong. It really had an impact when the patient came up with it, rather than us being reassuring, saying, oh, I'm sure that'll be fine, that'll be great. And they went, oh, wow. When we said, what did you learn from doing this movement, that mindfulness? They said, oh, it wasn't what I expected. And then we explored that further, and that seemed to make the shift. And I think one of the interesting things about the model is, in terms of the way our brains work, once patterns are set up, you can't delete them. There isn't a delete button in the brain like there might be on computers when you don't want one. Mm-hmm. But what we can do is change the frame by the context of the way we're talking about the person, not the bits that are wrong with them, the language we use, and the way we get them to think, as Jorge was saying, about the bits of them that do work and the things they can do, not just on what's wrong and broken, in a sense. So we fell into these theories by accident, but they really seem to fit what happened in a very practical, clinical way.
Yeah, and the interesting thing, we started talking about this stuff, a year ago. It's the sort of, the conference in Catania and so on. I remember sort of start diving into all this stuff, exactly a year ago and so on. And there are kind of lots of literature that actually, after a while, you think, okay, actually, this stuff kind of makes sense. In this context, and for example, the idea, that actually very simple thing, like the whole thing's about sense making, isn't it? What does it make? Each one of us, what does this mean to me, isn't it? And some people, clearly there's no two guys that have exactly the same thing, isn't it? So it's kind of how the system kind of appraises that as well. So it is interesting. There's one interesting question here from Annette. Again, does predictions of the operator also include things like our own physiological states? I'm thinking about our own physiology and how this may affect patients and their interoception. Yeah, absolutely. I think that's the thing, because even if you're thinking about something else, you're going to influence the system in a different way. And one of the first neuroimaging study that Francesco did was a simple task of palpating with attention to touch, and palpating whilst being, diverted. And clearly, what was observed in that study was, when you was palpating with intention and kind of focused on doing some stuff that felt like some myofascial release, the activity in the participant's brain was completely different, sort of really strong in the insula, so kind of salient network and so on. One was kind of something that you was still doing the same thing, but being bombarded with auditory signals from through the headphones. The activity was completely different. So yes, that is important, and that sort of fits also with the model in terms of being mindful, isn't it?
Yeah.
The kind of, how you approach things, isn't it?
Yeah, sorry, I'm just typing an answer to Laura,
Writing
just
the
in
paper.
case I didn't get a chance to say anything. There was a question about how we measured OsteoMap outcomes, and
Yep.
we weren't focusing on how much does it hurt. We were focusing on the patient's relationship to the pain, so how much the pain bothered them. So it fits with this model in that it's the way you interpret the sensations coming in. If you interpret it as pain, it's damaged, means I can't move, it's degenerative, it'll never get better, you have a very different sense of what your body can do and what that means for you as a person and your identity, than if you interpret it as an uncomfortable sensation because you haven't moved for a while, or you need to move in a particular way. So we were looking at how much pain bothered people, and we found that even though some people said my pain's just the same as it was, maybe it's worse, it comes, it goes, but I'm completely different. The way I feel about myself and the things I'm doing with my life are totally different. And it was interesting that the quality of life and the way that people coped with pain in a more active way, because it wasn't about them feeling confident or changing their cognitions, it was what they were actually going to do. Were they going to go and play with their grandchildren, or start gardening again, or paint, or do the things that, brought them joy and made them feel good? I've forgotten where I was going with this sentence. It was that the way that they coped with pain and their quality of life was directly related to how flexible they were in being willing to think about this, so that when the new input came in, instead of going straight to the old prediction, their salience network was somehow weighing, actually, what does this mean? Is it really pain and damage? Is it just a funny sensation? Can I afford to keep doing what I'm doing rather than kind of freeze and tense and make it worse? So there is something really interesting in there. I don't pretend to understand much of it, but it's a really fun place to start exploring what happens when you're working with people with really quite complex problems, which I think osteopaths do all the time. So bread and butter.
Sure. Yeah, and yeah, absolutely. And it's interesting because, if we look at the studies with with the persistent kind of conditions, that all seem to point to the same kind of pattern, isn't it? Which is around that kind of it's almost like people are locked in around that, including the ideas that you is the same sort of circuits for reward and and addiction and so on. So you kind of you become addicted to it. So can think about
to get rid of that, you have to find a different thing for people to attach to.
Absolutely.
So not just trying to avoid pain and control and pace and do things that won't make it worse doesn't actually move you towards the things that you really love to do in your life. So picking up again on what Laura said, I don't think my measurement of success is very relevant to patients, but asking them what matters to them and how well in the last week they've been able to achieve those things. Walk in nature, cook a meal for somebody they love, those kind of things. Those are the small successes that patients themselves value, and I can't guess what it is that makes somebody else's life meaningful. And as a very quick complete aside, we were using OsteoMap in a South London GP surgery with a guy who was a Rastafarian. He'd been homeless, he'd been alcoholic, he'd lived on the streets, trying to work out what mattered to him, and came out that he really liked cooking for other people, and the height of success for him was being able to make a Victoria sponge cake for his neighbours. I'd never have guessed that, but that's what he chose and that's what mattered to him. Yeah. So it is about people's context, their meaning.
Yeah, absolutely. And I think that's where we can change things, improve people's quality of life and so on. And I think it's a fallacy sometimes just go with how much is your pain today, and you move from 8 to 7, but that's 8 to 7 could be extremely meaningful for some people, isn't it? But you can say it's statistically non-significant anyway. So, or kind of expect that maybe you get 0 at some stage, which not entirely real. Okay, so yeah, I think that's it. Unless people have any other, questions. I hope you kind of enjoyed. You will receive this later on, not probably half an hour or so, when the system kind of uploads everything. You'll get an email with this, and will be shared as well. And UCO also will send you this, so you can go back and digest if you so wish. It's up to you guys. So thank you, everyone, and I hope to see you soon at some stage. Thank you, Hilary, as well. Bye.